today, so we're very glad to have you all here. I'm Dr. Joe Lizama, Vice Chair of Education, and very honored to introduce one of our young faculty stars, Dr. Shivan Shah. Dr. Shivan Shah is an assistant professor in the Division of Infectious Disease and International Medicine here at USF. Dr. Shah graduated from the Medical University of Lublin in Poland and then came to the US for his internal medicine residency in Kendall Regional Medical Center in the greater Miami area, and then to the center of the state to Orlando Health for his infectious disease fellowship. And then he did his oncotransplant infectious diseases fellowship, and then joined as a attending physician at Methodist Hospital in Houston, Texas. He has joined. He's been with us for about a year now, and he, in his short time on faculty, already has numerous publications on checkpoint inhibitors, which is his topic for Grand Rounds today. He also has, he was a co-author on a book for soft tissue infections. And so we are very blessed to have one of our young faculty stars from our outstanding ID division giving our Grand Rounds today on checkpoint inhibitors and infections, a need for antibiotic stewardship. Wonderful topic. Thank you, Dr. Shah, for putting this together. Look forward to this very important presentation. Go ahead.
Thank you so much for that introduction. Hello, everyone, and thank you for joining me. So today, yes, as we Dr. Lizama discussed, that we're going to talk about checkpoint inhibitors and infections, and just kind of a niche topic about a possible need for antibiotic stewardship. See if this goes forward. There you go. So today, just wanted to, the first time I ever encountered checkpoint inhibitors was actually during my fellowship, and it was ID fellowship. So we got called for an infection. And so I kind of wanted to bring this topic up because as I've seen patients and did studies with our hematology oncology fellows at Houston Methodist, it kind of, things got identified to me. So today we're going to kind of go over what are the risks with increased susceptibility to infection with checkpoint inhibitors. We're going to identify, common infections, what types of infections we have. Does this change our treatment outcome on patients if we label them with an infection? And possibly, come up with ways or discuss ways of what we can do to maybe do some stewardship with these patients. Just a brief picture with, this is pembrolizumab, but the way the immune checkpoint inhibitors work, basically, you just want the T cell to attack the cancer cell. And the way checkpoint inhibitor does work, this one, pembrolizumab, it has the interaction with the PD-L1 area, kind of make sure the cancer cell can't inactivate the T cell. So this kind of blocks it, inhibits it, lets the cancer cell, or lets the T cell attack the cancer cell. So instead of deleting or getting rid of cells in our body, we're actually using a way to make sure the cells work properly, which is great. Side effects of our ICIs. Now, that's such a wide range, and that's half the reason infectious disease will get called sometimes for some of these side effects. We get anywhere from just fatigue to all the way to pneumonitis. As you can see on this chart, patients will be complaining of diarrhea, painful joints, myalgias, things like that. So it's a wide range of symptoms, and we have to be on the lookout at it as clinicians. So something to always do. I like this chart, especially when I show patients. This is kind of what I will show them and say, look, you can get any of this stuff, and we're going to do our best to look to see if it's from your medication or from an infection. In my time, I wanted to always see what the rates, because that's always a question I have is, do we see more with different types of checkpoint inhibitors? Do we see less with other ones? Certain studies have shown, this one over here, that there could be with the CTLA inhibitors, about 54% of patients had an associated side effect, a little less in our PD-1 and L1 inhibitors. There was also a lot long-term immune related side effects in our CTLAs as well, up to like 85%. But the bigger question that I would get was what types of are more common. So this was part of that when a review basically on it, and one of the more common ones were dermatological issues or rashes, and then diarrhea was always a big thing we get called on to. So these are the different rates with the different medications. They range, 12% to 68%. It's a wide range based off numerous studies. So they can get it and any point. And that brought me to my next question always is, what's the time to getting an adverse event? So they vary, studies vary, but basically we would see that pneumonitis basically would be anywhere from 2 to 24 months with a median of 2.5 months. Colitis would be 6 to 8 weeks, but rashes can happen the earliest, I'd say 3 to 6 weeks. All of these would be issues that ID would also kind of see, because we would get called for possible pneumonia, possible, infectious colitis. So there would always be a question is, when was your last dose of your checkpoint inhibitor? And some patients didn't realize that it could happen 3 months later or such. So this was, especially during my fellowship when I was learning about all these, I kind of ran into this and I didn't realize and had to read up on it. Found out all this stuff. There's a grading of pneumonitis and colitis. I just wanted to kind of show, it can range anywhere from being asymptomatic to death. So you can have very severe reactions. It can be very detrimental to the patient too. This is the colitis one. Just you can have stools that resemble C. diff, and pain, fevers, wide range of symptoms. So it can easily be confused with infection. So that brings me to now the infection and ICIs. What are we looking for? How can we differentiate these patients? And it's very difficult. So basically, I ran into this study or meta-analysis to kind of start the topic up. During the meta-analysis, the overall risk of infections were low. Bacterial infections were the most common type of infection, and that could range from genitourinary infections, skin soft tissue infections, pneumonia, colitis. This is what they kind of found, though. ICIs were associated with similar risk of all-grade infections compared to non-ICI treatments. 9.6 versus 8.3. So ICI alone wasn't showing me that, okay, you're getting more infections or not. It was similar. ICI used alone compared to chemotherapy, it was actually associated with 42% less risk of all-grade infections. When you combined it with chemotherapy, that's when the infection risk was higher. And then the combination of ICI and chemotherapy also raised the risk of severe infections. So this was, okay, the ICIs are not the only reason. If you add something else, maybe that's the risk factor. This was another study I ran across. It was a retrospective review, basically from 2017. They ran it in 2017. They published it in 2022. It showed about 111 patients, and they basically had this. They looked at 3 different drugs: ipilimumab, nivolumab, pembrolizumab, and they showed what sites of infections you would have. So again, the most common ones with this were skin soft tissue, genitourinary, and then non-infectious pneumonitis actually was higher than just regular pneumonia. Bloodstream infections were there as well. And in this study, the range of bacteria that grew were basically Bacillus cereus, Staph aureus. And again, in the ipilimumab arm, and the infection rate was about 8, but the rest were a little lower. 8 patients, sorry. The types of infections, bacterial were the most common, as I kind of said before. Viral was less, and there was 0 fungal ones in this. So in this study, they actually looked at what was a different risk factors. So the steroids kind of came up in this. So about 111 patients received the ICIs. Suspected or confirmed bacterial infections occurred in 24% of them, and only 8% had confirmed bacterial cultures. That's a number that I'm going to bring up again towards the end of the talk. The overall serious infection rate was only 14%, and with 4 of the 16 patients had confirmed bacterial cultures. Patients on steroids was the only associated risk factor for serious infection. So about 12 out of 16 in the serious arm were on steroids versus 27 out of 95 in the uncomplicated infection arm were on steroids. So being on steroids was probably one of the bigger risk factors to have that serious infection. So from there, it kind of led me to ask, what are the rates of opportunistic infections? When we see some of these patients, especially in a oncology center, you get worried about some of these very odd infections. Sometimes you get your CMVs and your fungal infections and things like that. So was there a risk for these ICIs to cause this? And that's, where I did my next digging. You would find a few case reports of tuberculosis, aspergillus, pneumocystis pneumonia, but they still don't have known mechanisms for why some patients are getting it, why they're not, and still needs to be truly studied. However, I was able to find a good review on about 742 patients who received multiple courses of immunotherapy, about 908 courses to be exact, and even including combination therapy as well with ipilimumab and nivolumab. During this, they had 315 patients also had corticosteroid use, and of that, 56 patients also were treated with a TNF alpha inhibitor, specifically infliximab. And then a whopping only 2% developed opportunistic infections. So these included aspergillus, pneumocystis, strongyloides, candidemia, esophagitis from candidiasis, and then reactivation of VZV, HSV, and CMV. And as you can kind of tell where I'm going with this, corticosteroids and infliximab were actually what was associated with the opportunistic infection and getting the opportunistic infection. So it wasn't the ICI mainly, it was what we gave either afterwards, with it for treatment, things like that. So that also kind of gave me a thought, okay, maybe I don't need to worry as much about these opportunistic infections if patients just on an ICI. I wanted to delve deeper too, and I said, CMV colitis, I get asked about that. People get tested for it all the time who get ICIs because they come with bad colitis. So somebody will order it, and we get concerned. They call us for it. They may want to start treatment. So this was a study that I was able to read about. Basically, they want to evaluate the CMV incidence in patients undergoing ICI therapy, and they matched it with CMV positive patients in a non-ICI cohort based off age, sex, and cancer type. There's about 192 patients, and interestingly enough, it seems like the non-ICI patients had more CMV infection versus the ICI patients. So being on ICI, again, was not a risk factor to have a CMV infection or an opportunistic infection. So that kind of helped me identify that and even tell patients to hey, you're not really at risk. But if you were going to be put on a steroid or giving chemotherapy, then we have to rethink things about what we need to treat, what we need to cover. Because these opportunistic infections, and patients coming in constantly for infection, when I was at Houston Methodist, we had an idea with the HEMONC fellows to kind of see what happens with treatment for the cancer if patients labeled as having an infection. So basically, I brought up the fact that pembrolizumab, they have they report up to 90% of patients having genitourinary tract infections, and up to 44% of patients having a upper respiratory tract infection. When we looked at our patients at Houston Methodist, there was a label of about 46 patients developed a possible infection during their treatment time. The most commonly isolated bacteria, and these were the only bacteria actually that were isolated during the study, were E. coli and C. diff. We had rhinovirus, VZV, and herpes simplex that were also diagnosed, but they were much less. So the most common thing again was a bacteria that came about. Interestingly enough, during the course of the infection, there was treatment delays in about half those patients and discontinuation about 28 patients, about 25%, a quarter of the patients. Median treatment cycles received by the possible infected patients was about 5. Meanwhile, 8 was in the non-infected arm. So that was a significant problem for the patients if they weren't getting adequate treatment because they were labeled as infectious. We were delaying it because we were worried about an infection. Meanwhile, the cultures were, barely positive in patients. And the last thing we found in the study, that patients that were started on an antibiotic at the beginning of ICI initiation had higher associations with the development of an infection during their treatment during their treatment time. So maybe we were giving them C. diff, maybe we were giving them resistant E. coli's. It was we weren't sure. We couldn't study that particularly, of course, but that's something that we thought about. So that led me to think, what are the impact of the antibiotics we're giving? Is there something that we're doing wrong? Is there something that we need to look at? So good study out here that they looked at it, an impact of antibiotic exposure before immune checkpoint inhibitor therapy and the overall survival, the OS, in older patients with cancer. So it was a population-based study. There was about 2,700 patients who received ICIs, and 59% received antibiotics within 1 year before ICI therapy started, while 90% received within the 60 days before ICI therapy. The median overall survival for the patient cohort was about 306 days. Interestingly, any antibiotic exposure within 1 year before ICI therapy was associated with worse overall survival. The adjusted hazard ratio for worse overall survival was 1.12, so significant. The exposure to fluoroquinolones within the year was also associated with worse overall survival. That again showed the adjusted hazard ratio was 1.26. A similar trend was observed in patients who had fluoroquinolone exposure within 60 days, but it wasn't statistically significant. There was also a dose effect observed for both total weeks of antibiotic exposure within the 60 days before ICI therapy as well. So that being said, we have patients that constantly will get outpatient antibiotics with Levaquin. It's a fairly common drug, and we see this could be detrimental to the patient. And I'll go over into more detail soon, but this was an area that I wanted to really look at too. Is the outpatient area causing a lot of issue? Are patients going to their primary care physician saying, I have diarrhea, I think I ate something bad, and they get Levaquin or Cipro, and is that causing more harm than benefit for the patient too? And are we also missing an adverse event or adverse reaction from the ICI? So to touch now, that's what brings me to my next thing, is the microbiome. Now, this is all kind of leading towards that, is what are we seeing in the microbiome that could be causing? Are we harming the microbiome? Is it making our immunotherapy less effective? Is it causing more adverse reactions to develop? So the impact of immunotherapy response is basically the gut microbiota has this tumor microenvironment, and it helps the tumor will impact on ways our immune cells work too. So if we change the microbiome, does that affect our cells? Is there certain metabolites that the microbiota will play to fight off cancer or help with help the immunotherapy work better? These are all being studied, but there's more and more data showing that certain bacteria are better to have in our gut versus other bacteria, maybe because of these microbiota. And it's an ongoing thing going on. There's a good timeline that shows how it kind of is. We've been having from like 2007, sorry, to now. We've looked at different type of studies. First started off with gut microbiota stimulating anti-tumor responses and antibiotics given to see what happens in mouse studies. And we got actual human and mouse studies later on showing immunostimulatory, immunosuppressive tumor microenvironments, followed by prospective and retrospective studies. These all had various data points that were leading towards, hey, maybe there's something going on that we have to worry about, and what can we see? So one thing I picked up here, it was 2016. So one of the studies on the intestinal microbiome to identify the risk of having this adverse effect from our immunotherapy. It was a prospective study. Basically, it correlated pre-inflammation fecal microbiota with subsequent colitis development. Increased representation of the Bacteroidetes phylum correlated with resistance to checkpoint blockade-induced colitis. So there was a bacteria or a group of bacteria that actually helped reduce chances of getting checkpoint blockade-induced colitis. So pretty interesting, subject to see. And, there's more and more different bacteria they're studying as we go on. Then there was also, is there intestinal microbiota signatures of clinical response and immune-related adverse events in melanoma treated patients? So they looked at different groups of bacteria to see which ones were positive and which ones were negative. So we saw in this meta-analysis basically that bacteria associated with favorable outcome were in the Actinobacteria phylum, the Lactinos, I mind my pronunciation, the Spirae, and the Ruminococciae, gram-positive bacilli families of firmicutes were also linked to favorable responses. However, gram-negative bacteria were associated with inflammatory host intestinal gene signatures, which had increased neutrophil lymphocyte ratio, which was an unfavorable outcome. Basically, are we changing the gut by giving antibiotics and causing more of these gram-negative bacteria to cause more harm than good? So they've looked into this as well, which leads me to my next point is there a role for fecal transplant in these patients? Now, recently there was, and I'll go over a phase 1 trial that came out that they discussed this, and there's various articles about, can the fecal transplant help out with checkpoint inhibitor induced colitis that's refractory to steroids, or using it to help with immunotherapy resistant neurological tumors. So this was the phase 1 trial that they released. Basically, the fecal microbiota transplant alone, the FMT alone, was tolerated. No grade 3 adverse effects events reported when they did this. However, given with a PD-1 inhibitor, 25% of patients experienced grade 3 immune-related adverse events. The response rate giving it was about 13 out of 20 patients achieved response, and 4 patients achieved complete responses, which is awesome. What they found also with the microbiome changes, the ones that fully responded actually had the engrafted strains from the donors completely. So that is a way more favorable outcome if you end up having the change in microbiome from the donor, from the FMT, to have benefit of the immunotherapy. What kind of they want to do now is, it's Safe. Well, it's safe to do in the first line setting. However, we do need more and more studies to see if it's better than standard of care. So doing an FMT, will that help? We don't know yet, but it's ongoing right now. They're doing more and more studies with it, and I think it has a potential of actually gaining favor in the future. So where do we go from here now? Basically, I'm mainly located at Moffitt Cancer Center, and I was able to work with our wonderful pharmacy team here, Max, Yanina, Stephen. Max wanted to study, you know, what is going on with us giving antibiotics in these patients. So he's objective. He wanted to do a study where we wanted to see the rate of microbiologically positive and clinically confirmed infectious colitis, but also look at the rate of empiric antibiotic initiation and antibiotic use among non-infectious colitis. So what was causing us also to start the antibiotic? Is there certain symptoms that physicians and providers were worried about? And then also looking at mortality. So what we found, interestingly enough, is only 10% of patients had true infectious colitis. Going back onto before, where we had only 8% of confirmed microbiologically confirmed cultures in patients with GU and other things. So it relates to that we're not seeing actually a lot of bacterial infections, like proven bacterial infections, and it's actually much less than we anticipated. Again, the most common ones were around E. coli and C. diff. What we did find, though, is about 50% of these patients received antibiotics. And among 90 patients with non-infectious colitis, 46% received antibiotics. And the mean duration of the antibiotic use was about 4 days. So, it's a pretty significant long time. We treat UTIs with 3 days a lot of times. So 4 days is not insignificant. We also looked at, when we reviewed it, we looked at what was the appropriateness of the antibiotics. So of the patients with appropriate antibiotic use, only 5 of them actually had culture positive and clinically confirmed infectious colitis. So we found that a lot of patients that were inappropriately given antibiotics, about 65%. So a lot of antibiotic use that, as I showed before, may be harmful to the patient, may not be beneficial for them to get their cancer treated. And then the conclusion of this study, basically, 90% of patients evaluated had non-infectious sources of colitis. Despite the low rate of infectious colitis, nearly half received the antibiotics, as I said. And then antibiotic initiation, what they found was actually associated more with when patients had a fever or they had a history of chronic infection. So a little bit of bias that, we see fever and the patient had a history like 2 years ago of this E. coli in the blood. So it may have caused us to start antibiotics. But what we didn't see, unfortunately, is, de-escalation within 48 hours. It was patients on it for 4 days in the meantime. So that was an area I think we wanted definitely to work on. So that leads me to kind of like one of my final points in this talk is possible ways to implement stewardship. So over here at Moffitt, they actually created a dedicated service called the iTalk service, where they're getting these patients in, and they have a SOP, inpatient SOP, that we start antibiotics for 48 hours, de-escalate once we see, but also starting steroids for these grade 2-3 adverse reactions, which decrease, hopefully when we look at it in the future, because it just started, that we could see if it decreases length of stay, decreases antibiotic use. So this is something that we're trying to work on right now. One area that we definitely need to work on is creating some sort of SOP for our outpatient side. Patients do complain of side effects of these, but we might just say, oh, you might have a little infection, let's give them Cipro, or let's give them Doxy for a skin reaction potentially. So what, the overall goal is maybe educating outpatient providers to not just throw antibiotics on right away and, observe to see if this is something else going on. Making use of our early testing to our PCR tests and then de-escalating based off of that. Sometimes we do the testing and we end up not de-escalating because we have a feeling that, maybe this is really an infection and we shouldn't stop the antibiotic. So basically, the providers should look into this, always look into trying to stop the antibiotic if we see that, this likely could be a 90% of the time likely is not an infection and it is a adverse reaction. And then, finally, just after looking at everything, this is about antibiotic stewardship I kind of was discussing, but diagnostic stewardship is also a real thing. And that's something that, I feel like we can make better use of, not ordering our CMV PCRs in these patients that aren't on steroids or other chemotherapies, that have way lower risk of it. So I would, ask all the physicians and say be a little more prudent and looking into what you're going to order as well before just jumping the gun, getting it, and then even if it's slightly detectable, are we going to act upon it or not? So that's something that these are kind of 4 things that I wanted to bring up for that. So basically, just as I kind of was going over, is checkpoint inhibitors and adverse reactions can be confusing with infections, but it's our job to kind of go through that. Always ask your ID provider if you're really confused too. We're happy to help. We should recognize the risk factors. Steroids, chemotherapy, that is a higher risk factor for having a true infection, and those people might need to be on the antibiotics longer. Know that there is some detriment to giving antibiotics for a long period of time. It decreases the efficacy of checkpoint inhibitors. It doesn't allow patients to get their treatment on time. Sometimes if we label them as having an infection, they may have to discontinue it. So it can be harmful to the patient too. And then just looking into FMTs for the future may be able to help with adverse reactions and increasing the efficacy of these agents. So, for me, this is something that, it's an ongoing thing. We're learning more and more every day. Next year, we'll probably have a lot more information. And, I'm excited to kind of see where this all leads to. And if, the future is we give fecal transplants to patients or and avoid antibiotics and maybe kind of see if that works better for patients. It'd be exciting to see that. So thank you so much. That's it for me.
Dr. Velez?
Dr. Shah, thank you for a great presentation. I have a question. Did you happen to find or see any article about secondary PJP infections on patients who have pneumonitis due to checkpoint inhibitors that have been treated with chronic steroids? Thank you.
Yeah. So there is articles, there's case reports about patients getting PJP, but it's always after they're on the steroids afterwards for the adverse reaction. That's where it typically happens. And some patients aren't on prophylaxis because of the steroids. So, and that's risk versus benefit of, one DSTID or 3 times a week probably won't affect the microbiome as much, but getting PJP is more harmful. So that's something, but most of them are case reports showing this, that it's usually from steroid use after having an adverse reaction.
Thank you.
Dr. Quillitz?
Thank you, Dr. Shah. I would appreciate any thoughts you might have as far as how we can make the determination in the setting of suspected ICI pneumonitis because I think that's an even harder situation than the colitis. So we often have patients who are respiratory colonized, maybe MRSA colonized, and it gets pretty sticky.
Yeah, and unfortunately, that's very difficult. So number one, I would say, is always do our due diligence and do a workup. One big thing is a bronchoscopy always helps if possible. So getting the data. Now, if they've been MRSA colonized and you see it multiple times, you can start with, the antibiotic 48 hours. If they're not improving, that's something that you got to say, hey, start the steroids. We can continue treatment while on the steroid. As you know, the steroid will make them more immunosuppressed, but you don't want to hang your hat on just a bacteria, as you can see most of them. And again, CT scans help, things like that. We could see if we see more clear pneumonitis picture versus a bacterial pneumonia picture, it can be seen on CT too. So just doing the full workup always helps with that picture. And it is tricky. There's no one right answer to this, but I think, just throwing antibiotics and not getting to the root cause is always an issue.
Dr. Ledford, would you like to ask your question from chat?
So yeah, we did not. No, yeah. So yeah. How do you balance? Is there supposed to say how do you balance, Dr. Ledford? So balance, yeah. So to balance that, basically, so we're never going to say no to steroids for the most part, and we could treat, but if we see, these patients, if cultures are negative, they did a bronchoscopy, we do our due diligence, culture, everything's are negative, if it's certain bacteria like MRSA or like staph, pseudomonas, they're likely going to grow, especially on a culture thing. So you could give the steroids. Giving the steroids is okay. It's just making sure you don't hang your hat on one or the other. Like, it's not an infection, or it is an infection, but it's going to take time. What we want to make sure is not throwing antibiotics on, not following up with the patient, and making sure. Over time, we're probably going to see more and more data showing that there's less of risk of infection, but judge it based off of, hey, this patient has gotten chemotherapy with their immunotherapy, they're on infliximab, they have a history of TB. So there are different elements to each patient that we have to look at. So getting a thorough history on it, that's probably one of the biggest things that I ask for, and all our physicians and providers too, is just, do your due diligence for that.
Go ahead, Dr. Velez.
Yeah, that's a great question and a great conflict that we see in infectious diseases. Oftentimes, patients hold on steroids for severe cases of pneumonitis because of the fear of long-term consequences. And we, in med school, we were always told that ABC comes first, and A is the airway. So part of that is ameliorate the immune response that will progress, and these patients go on respiratory failure, oftentimes on high flow, and then they don't do they cannot do bronchoscopies because of the high risk. So it's always better if you suspect an infection, but you suspect pneumonitis, as you're treating empirically for pneumonia, it's very important to treat empirically, but very important to treat empirically for pneumonitis to prevent that respiratory failure. So you eventually can get some culture data and then decide what's the best for the patient. You can always worry about the long-term side effects as long as the patient is alive.
Thank you, Dr. Velez. Yes, I agree. That's one of, it's not going to be a one or the other thing. It's going to be a time, over time we get this data. So definitely stabilize the patient, and then we can work out de-escalating or escalating the patient on antibiotics. And thank you for mentioning my dog. She is very, she didn't let me work on this most of the time.